Okay, so I'm going to give an overview of what's known about the health of autistic people, and then share some preliminary data from two of my research projects, barriers to primary healthcare for autistic adults and the experiences accessing mental health services. But first, I want to start by addressing a question that was raised at last week's webinar, because this touches on my current work on peer support and advocacy for autistic doctors. And the question was, should diagnostic teams have autistic members? And the answer is many already do. Autistic professionals exist in all fields. In healthcare, we have autistic doctors, nurses, pharmacists, occupational therapists, speech and language therapists, autistic psychologists, psychotherapists, and many are thriving in a supportive environment. Many more are seriously struggling, but most of us don't disclose our diagnosis due to stigma and unconscious bias. So lots of you may be working alongside autistic colleagues already, or indeed you may be autistic yourself. This poster was presented at a recent anaesthesia meeting. Now, I'm obviously not the first autistic doctor, I'm just one of the first to talk about it. And 3 years ago, I didn't know a single other healthcare professional who was autistic. But since I founded the Autistic Doctors support group, the growing membership supports my view that there are many of us, because medicine selects for autistic traits. And then when you look at the breakdown of specialties, this is from a spot poll a while ago, GPs are the most common, psychiatrists are second. And when you consider the relative numbers of GPs and psychiatrists, it's clear that autistic doctors are overrepresented in psychiatry. And those of you who use the DSM regularly may recognize Dr. Robert Spitzer. He died in 2015, and he was primarily responsible for the removal of homosexuality from DSM-2 in 1973. And to quote Alan Francis, that was the result of his single-minded and almost single-handed crusade to eliminate the psychiatric stigmatization of difference. His other major accomplishment was to save psychiatry from a crisis of credibility in the 60s and 70s by systematically developing the DSM-3 and its subsequent revision. I first read about him in Steve Silverman's book, Neurotribes. As I did, I noticed a lot that was very familiar. Now, this is a whole other talk, but briefly, to quote Steve Silverman, while Spitzer's eccentricities may have fallen short of meeting the criteria for Asperger's, the DSM-3 was the product of a mind that exhibited many classic qualities of autistic intelligence. Wouldn't it be the most supreme irony if the man who created the Bible on which modern psychiatry is based was one who thought like us? What more evidence could we need that diversity of thought within medicine is vital and that we need to recognize and celebrate neurodiversity? But let's move on to healthcare. We know from several large studies that autistic adults experience worse physical and mental health than non-autistic people. And at this point, I should say that if you haven't heard about our healthcare outcomes and our mortality statistics, including our suicide risks, then this could be upsetting, particularly if you're autistic or a parent. The figures I give, it's important to remember this, the figures I'll give relate to the autistic population as a whole and do not indicate outcomes for individuals. While of course autism is not a mental illness, it is associated with mental health, co-occurring mental health conditions in up to 80%. So anxiety, depression, bipolar disorder, OCD, eating disorder, substance misuse, all very common. Missed and misdiagnosis is a particular issue for women. And we know that in particular, borderline personality disorder is a frequent misdiagnosis. Suicide's an autistic crisis, with rates for autistic women up to 13 times the general population rate. And figures in the literature of 2/3 having contemplated and 1/3 having attempted suicide. 15% of those hospitalized after attempted suicide have a diagnosis of autism. And a psychological autopsy study shows that 11% of those who died by suicide had evidence of autism. For current thinking around psychiatric illness in autistic adults, I'd recommend the Royal College of Psychiatrists 228, published last year, available to download from the college website. And I'm proud to have been a member of the working group that produced the report. Moving on to my own work in this area. This is a study undertaken in collaboration with Professor Louise Gallagher and As I Am, and we looked at the experiences of autistic adults attending Autiscape, which is a residential conference held annually in the UK, organised by and for autistic people. And while the qualitative data is awaiting formal thematic analysis, I'll present some of the preliminary quantitative data. 18% were attending a psychiatrist at the time of completion, 61% having attended in the past, and 43% described difficulty attending. Now, this project is moving more slowly than I had hoped, mostly because it's just so painful to work on. How have we reached a situation where we, as a community, are so marginalized and so misunderstood that 86% of us have felt that life is not worth living? 47% of the respondents had attempted suicide at some point. 65% had engaged in self-harm, which is not something that's widely associated with autism amongst healthcare providers. And for 21%, this required medical attention. And few of my colleagues treating patients following an episode of self-harm would consider autism. 27% had been psychiatric inpatients. 11% had been detained under mental health legislation, with 10% experiencing restraint. 28% said they used alcohol to manage mental health issues, with 11% using illicit drugs. And while most of us are familiar with the mental health challenges, the mortality gap and the physical health conditions associated with autism are less well known. Some of you may be familiar with the 𝗗𝗿𝘆 study, where they looked at a large population-based cohort of 27,000 autistic people in Sweden. They examined all-cause and cause-specific mortality and found that the mortality rate for the autistic group was 2.5 times the general population rate. Other studies from Scotland, the US, and Australia show similar patterns. And there's also a recent paper showing that even our in-hospital mortality rate is doubled. So while the average life expectancy in the Swedish study was 70 years, for the autistic group without intellectual disabilities, it was 54. That's a mortality gap of 16 years. And for those with co-occurring intellectual disability, average life expectancy was just under 40 years. And the leading causes of death in the autistic group were heart disease, suicide, and epilepsy, but in almost all the diagnostic groups, including cancer, lung disease, endocrine disease, mortality rates were increased for the autistic group, except for infections, which is interesting in the context of the current COVID crisis. Autistic people experience higher rates of conditions such as diabetes, obesity, high blood pressure, high cholesterol, stroke, epilepsy, Parkinson's, sleep disorders, digestive disorders, and more recently recognized Ehlers-Danlos or hypermobility syndromes. It's known that autistic people face healthcare inequalities with access barriers due to patient-provider communication difficulties, sensory issues, executive functioning or planning issues, as well as prior negative experiences with healthcare, which is an independent barrier to future care. Autistic patients are 3 times more likely to attend emergency departments, 3 times as likely to be admitted from an emergency department, and most worryingly, 3 times as likely to die after an emergency department presentation. So we must ask, is this because autistic people delay seeing their own doctor or have no doctor, and therefore present later in the natural course of an illness? My work in this area started as part of the As I Am 𝗗liche Autism Friendly Town project in 2018, where I was asked to develop autism training for healthcare providers. And to ensure the training was informed by the lived experiences and the concerns of the autistic community, I undertook a discussion workshop and survey at Autiscape, followed by an online survey comparing autistic adults, parents of autistic kids, and a control group. And we asked, what are the barriers faced? What do our GPs need to know? What works well? What would make visits easier? And what are the self-reported consequences of delayed care? Our paper is currently in review, and while I don't have time to go into the results in detail, a preprint is available on medRxiv, and hopefully we'll have a peer-reviewed paper soon. We had 860 respondents, most of whom were autistic, with 74% having a formal diagnosis. We asked, do you have difficulty visiting your doctor when you need to? Not in general, but when a visit is actually required. And over 3/4 of the autistic group, half the parents and 1/3 of the controls said yes, they had difficulty. 78% of autistic respondents avoid using the phone in general, and this is the most common barrier to accessing healthcare. This isn't something that's widely appreciated outside of some specific autism services, and it's one of the most urgent areas to address. If your service relies on telephone contact and you don't offer an alternative, then that service is inaccessible to a majority of autistic people. 55% do not attend a GP when required because of not feeling understood. So they just don't go. Sensory issues, executive functioning issues, and concerns around disclosure also featured prominently. Let's focus on communication for a minute. 72% said anxiety makes it harder to communicate. And this is true in all aspects of life for autistic people, and specific measures to reduce anxiety would have enormous benefit in the context of healthcare. And as autistic people, we know this. As professionals, we see it. But how often do we make adjustments? Do we assume this is a patient's baseline? Concern at not being believed or taken seriously is a significant barrier. And given the non-presentation of serious illness, which I'll talk about in a moment, it's a specific challenge to address. The communication differences which are inherent to autism can pose really particular challenges in a healthcare setting. Expressing emotions differently, such as appearing to be angry when afraid or in pain, or describing pain without the expected non-verbal signs of pain, can lead a doctor to underestimate the level of distress. But here, just look at the intergroup differences for none of the above. When we asked how often communication difficulties were encountered during a consultation, 90% of autistic respondents said all the time, frequently, or sometimes. Executive functioning is an issue. Over-inclusiveness is common. Difficulty knowing what's serious, what's not, what to include, what to leave out. Difficulty summarizing, and just a sense of needing to give the whole story can be a challenge, particularly in a short appointment. And as a healthcare provider, I know it can be difficult to manage, but being able to email in advance the reason for the consultation would effectively deal with this problem. Again, look at the intergroup differences for none of the above. Because the difficulties we face in managing to arrange and attend a medical appointment are just simply not experienced by non-autistic people, and therefore they're often not understood. So what helps? A preference for online booking was shown across all groups, but next most important, as I've mentioned, for the autistic group was the ability to email in advance the reason for the visit. Being allowed to wait outside should be easy to accommodate, particularly post-COVID, as would an appointment at the start or the end of a clinic. The consequences of access barriers to healthcare include untreated physical conditions, untreated mental health conditions, late presentations, emergency admissions, more extensive treatment or surgery. And most worryingly, a third of autistic respondents reported a potentially life-threatening condition which went untreated due to inability to access healthcare. And many autistic adults have no access to primary care whatsoever. And there were no differences with or without a formal diagnosis in terms of difficulty attending, barriers faced, or adverse health consequences. So based on this research, I believe these are important factors contributing to the excess morbidity and mortality for the autistic community, and they're the most urgent to address. So what does this mean in an Irish context? Potentially large numbers of Irish autistic adults, many undiagnosed, facing significant barriers, significant challenges accessing basic healthcare, and likely to be experiencing increased morbidity and mortality. And yet outside of the intellectual disability services, we're an invisible cohort in Irish healthcare. We urgently need to develop diagnostic and support services for autistic adults as part of our public health system. It's deeply concerning that a condition with such profound health impacts currently receives no funding or provision in primary care, secondary care, or social services. Both of my surveys show a worryingly high rate of autistic people not registered with any GP. The greatest barrier is the phone, and so I'm particularly concerned about our community during COVID with the move to telehealth. This is a matter of human rights. Equality legislation requires that accommodations be made. So, for example, failing to provide an alternative to use of the phone to access your service is potentially a breach of your duty under the Equality Act. But it's not just a legal requirement, it's a moral duty. We would never deny a wheelchair user access to healthcare services for want of a lift or a ramp. Accessible communication alternatives to the phone are equally important for autistic people. It's vital that we accelerate the move towards a strengths-based approach to autism and resist the tragedy narrative that's so pervasive across healthcare. Education and training will be required for all staff in both physical and mental health care, and this must be informed by the lived experience of autistic adults. It's ideally developed and delivered by autistic healthcare providers. So we need to challenge the assumption that we can often have as professionals that autistic people are our patients, our clients, and recognize that autistic people number among our colleagues. Making healthcare services autism friendly involves first recognizing, valuing, and learning from our autistic colleagues. The way to join the Autistic Doctors private group is to send a message via the public page. Follow us on the public page for updates. You can find me on Twitter, where I tweet as the Autistic Doctor, or feel free to email me directly. Thank you.